So the urinary system. This is a really critical system when it comes to fluid balance, blood pressure, electrolyte balance, and pH in the blood. So when you look at a patient, like a lot of our patients in the hospital, homeostasis gone bad, right, ends you up in the hospital. A lot of patients have trouble with their kidneys, kidney function. And many diseases that we see out there that are real common in the United States, like high blood pressure and diabetes, lead to kidney disease. So you're going to see patients with kidney disease, but that have these other more common disturbances like blood pressure, heart failure, and diabetes. So the kidneys, their job, well, first of all, what they look like, if you saw them in a cadaver, they're about the size of a bar of soap. So they're not very big. But inside of these kidneys are the many, many nephrons that are actually filtering the blood and making urine from that blood. And there's millions of nephrons in the kidneys. So we have many, many nephrons. And when we start to decline in our kidney function as these nephrons break down with age, we don't start to see the symptoms of kidney disease until you only have about 25% of your functioning nephrons. So the kidneys are really able to adapt. Like, you know, some people that maybe lost a kidney or were only born with one kidney, that's not an uncommon congenital problem. The other kidney will pick up the pace for the slacking kidney. So some people have a failing kidney and don't even know that they have a bad kidney because the other one picks up the pace. So they're really efficient at what they do as long as we keep them healthy. So functions then, filters the blood. So the dirty blood that needs to be filtered comes into the kidney via what vessel? Renal artery. Yep, renal artery. And then that artery branches and branches and branches to finally become the afferent arteriole. Remember we studied that in lab? And then that plasma is filtered out. So the filtering of the blood occurs through the kidney. And because of that ability to have, of plasma to leave the vascular system at the glomerulus, the kidneys are efficient at controlling blood volume. So if we have a lot of filtering going on, blood volume will go down. If we slow the filtering, blood volume goes up. What gets filtered are the solutes in the blood, and what are some solutes? Some things that are dissolved in our plasma. What's dissolved in our plasma, John? Urea as a waste product. When we eat protein, our body breaks, with the help of the liver, breaks that into urea. So that's a waste product when we eat proteins. What else? What's dissolved in our blood right now that your body needs, every tissue cell needs? Electrolytes like sodium, chloride, potassium, you know, all those. Calcium. Rachel, you mentioned one? Glucose is essential. So those are some dissolved solutes that can be regulated by the kidneys. Glucose is not so easy. We'll talk about that. So the pH of the extracellular fluid, what ions contribute to pH? The two primary ones. What ion makes our blood acidic? Hydrogen ion, right. What ion helps make our blood more basic? Do you remember that ion? It's a polyatomic ion. Yeah, bicarbonate ion, very good. So those two ions are regulated primarily by the kidneys. And blood cell synthesis, do you remember the hormone that the kidneys release when oxygen levels get low? The kidneys release this hormone, and which acts on the bone marrow to make more red blood cells a little faster. Yeah, erythropoietin, EPO is how we abbreviate it. Blood doping, remember people use blood doping to try to get more red blood cells, to stimulate their kidneys to release this hormone so they can perform better in athletics. And then synthesis of vitamin D. So remember, vitamin D synthesis begins in the skin, but that molecule is not complete yet. It's not ready to go. So it travels to the liver first. The liver manipulates it a little bit. Then it travels to the kidneys. The kidneys manipulate that molecule. Then it's secreted to the small intestine, where it helps us absorb what? What do we need vitamin D for? Yep, to absorb calcium. So this we can see the blood flow. So we have the renal artery, branches and branches and branches into this last artery, or the last two arteries, the arcuate artery, the interlobular artery, which then becomes the afferent arteriole. And then it, again, the glomerulus is a holy, has a lot of fenestrations, we call them, to allow plasma to leak out of it, and then that blood returns and leaves via the efferent arteriole to become another special blood supply, which are the peritubular capillaries. So these wrap around the nephron. Just like we saw the pulmonary capillaries wrap around the alveoli, so there's exchange of gases right between the pulmonary capillary and the alveoli. Same thing occurs here. We have not gas exchange, but ion exchange and waste secretion and water exchange occurring between the blood and the kidneys, between the nephron and these peritubular capillaries. And down here in the loop of Henle, we have a special network of blood vessels called the vasa recta. But the key point to know is that there's an exchange between the blood and the nephron through these tiny little capillaries. So the glomerulus is the only capillary bed in the body that has two arterioles. Because when we studied capillary dynamics, didn't we find that there was an arterial end and a venule end, right? On either side of the capillary bed? Well, the glomerulus is unique in the body that it has two arterioles. So with this process, the squeezing of the plasma out of the glomerulus, this is so efficient that if we did not have reabsorption, where we take this fluid out of the nephron and put it back into these capillaries, we would pee away our plasma in about 30 minutes. So we filter our entire blood volume in about 30 minutes. So it's important that we have this reabsorption occurring. So of the fluid that enters the nephron, what will eventually become urine, enter the collecting duct and the pelvis and the ureters and the bladder, is about 1.5 liters a day. And you need to know that number, especially for the final exam. 1.5 liters of urine is produced a day. Or something close to that. You might see a little variation, 1.6 or something like that. But 1.5 on average is about how much urine. If we're well hydrated and things are just perfect, all's right with the world, 1.5 liters leaves the body as urine. So other structures of the urinary system, the ureters, remember, that's what drains urine from the kidney via peristalsis, that smooth muscle contraction, carries urine from the kidney to the bladder. The bladder's only job is to store urine, so it's lined with smooth muscle. When it stretches, it's stimulated to contract. And the urethra, we have an internal and external urethra. The internal one we cannot control, the external one we can. So we relax that when we're ready to release, allow urine to flow out of the body. So again, we have this blood that needs to be filtered coming in through the afferent arteriole, which is more muscular. Blood under high pressure comes in and is squeezed out into the first part of the nephron, and this is Bowman's capsule. And then from there, whatever gets filtered, which is non-selective, filtration is non-selective, so we're just squeezing all this stuff out, all this plasma out, some of which we need to take back, like glucose and electrolytes. We can't let that all enter the urine. So we have this process, which is called, labeled number 2 here, which is reabsorption. So you might want to label that. Number 1 is called filtration, non-selective filtration. Reabsorption is selective, depends on the environment out, around the nephron and the capillaries and the interstitial fluid. So this is reabsorption, number 2. And the third process that occurs here in the kidneys is secretion. So we're taking things from the blood and adding it to the nephron. So if we're looking at nutrients and electrolytes and water, that would be reabsorbed because we need that stuff back. And if we're looking at metabolites of drugs, excess ions like potassium and sodium, which often we have excess, that we're going to secrete into the nephron from the blood. So secretion is usually waste products and excess ions like sodium and potassium. So again, you have to know the 3 processes that occur in the kidney. Filtration at the glomerulus into Bowman's capsule. Reabsorption that occurs in the first part of the nephron, primarily in the proximal convoluted tubule. And then secretion, which occurs toward the end of the nephron, specifically the distal convoluted tubule, where we're adding things from the blood to the nephron. So just know the direction that things are moving. Filtration is from blood to Bowman's capsule. Reabsorption is from nephron to blood. And secretion is from blood to nephron. Filtration is going from the glomerulus to Bowman's capsule, so it's leaving the vascular system. Reabsorption is going from the nephron to the blood, and secretion is going from the blood to the nephron. So this nephron is essential. And we say that the kidneys filter the blood. It's the nephron that is doing the filtering. So this plasma is squeezed out of the glomerulus, enters Bowman's capsule, but it's what happens beyond there that determines if we're going to maintain homeostasis, because we said filtration is non-selective. So we're squeezing out glucose because there's glucose in our plasma. We're losing glucose, electrolytes, water. All that is entering the Bowman's capsule. What would not enter Bowman's capsule? What are some things that would remain in the plasma? What are some things that are too big, did we say, to fit out of, when we studied capillary dynamics, what are some things we said can't squeeze out of the capillary? John, you had your hand up. Red blood cells is one. Proteins is another. What other solid cells do we have in our blood besides red blood cells and proteins? Well, proteins aren't a solid cell, though. What? No. What? No, those are dissolved. Those substances are dissolved. What are solid elements in our blood other than red blood cells? White blood cells, right? So should we see pink urine? That would mean red blood cells are in the nephron. They shouldn't be there. Should we see cloudy urine? No, that would mean white blood cells and bacteria are in that nephron and urine. Bad news. And protein you're not going to see. We test for protein with a dipstick, and sometimes that can indicate issues, problems, especially in pregnancy. We look for protein in the urine, and that is a bad sign of, what is it called, preeclampsia. So that's not something that should normally, we can see a little bit of protein in the urine. Sometimes a little protein squeezes out. Remember we talked about the interstitial fluid sometimes has a little bit of protein, but not a lot. Very small amounts of protein. Okay, so the nephron is the selective portion. So most reabsorption of these important things, all the glucose, all the amino acids, we don't want to lose that. We want to take that back to the blood so that all is reabsorbed right when it enters the proximal convoluted tubule. So even though it's squeezed out into Bowman's capsule, we take it right back at the proximal convoluted tubule. And then we have some reabsorption going on here in the loop of Henle. On the descending side, water leaves and goes back to the blood. And on the ascending side, sodium leaves and goes back to the blood. So we have reabsorption going here in the loop of Henle. So by the time we get to the distal convoluted tubule, there's not a lot of reabsorption going on anymore. It's mostly secretion that happens in the distal convoluted tubule. And the collecting duct is important because hormones act on the collecting duct, a little bit on the distal convoluted tubule, specifically one hormone which we'll talk about, which is ADH. But we'll talk about that in a little bit. So when we talk about the kidneys filtering urine, we say that the nephron is the structural and functional unit of the kidney, which means it's doing the job of the kidney, the nephron. So that's the functional unit. And the kidney is made up of millions of these, so it's the structural unit of the nephron as well. Like if I talked about what's the structural and functional unit of this classroom, it would be the students, right? Because there's mostly students in this room, and you guys are the ones that are working hard feeding into the community with your education. So the collecting duct, just one more thing, is not part of the nephron because there's more than one nephron that hooks up to it. So it ends with the distal convoluted tubule. So we talked about filtration is everything except for the blood cells and the proteins. And most of what is filtered is reabsorbed back to the blood. So 99%, only 1% becomes urine. So we talked about the membrane. This is the filtration membrane. This is talking about the membrane of the glomerulus. It has little holes in it. That's what fenestrated endothelium means. It means that capillary of the glomerulus is made up of simple squamous cells. It has little holes in it to allow substances to filter out very easily. So this is the most leaky capillary bed we have in the body because we need to get this stuff out of the blood and then selectively reabsorb what we need back. We have different pressures. We studied capillary dynamics. So we have hydrostatic pressure in the glomerulus. And if we subtract the hydrostatic pressure in the Bowman's capsule and subtract off the pressure of the proteins in the capillary bed that would suck fluid back in, we get the net filtration pressure. So the hydrostatic pressure of the glomerulus is 45 millimeters mercury. The hydrostatic pressure of Bowman's capsule is 10, and then the plasma proteins in the capillary are going to suck inward with an osmotic pressure of 28. So remember, if we add up everything that's acting outward, which would be the 45, subtract what's acting inward on that plasma, and we end up with a net filtration pressure of 7. Does it make sense that this number should always be the highest, the glomerular capillary pressure? Because we need to get stuff out of the capillaries, right? So what happens, what would increase this? What would cause this number to increase? What conditions in the body would cause that number to increase? High blood pressure, for sure. What are some things that lead to high blood pressure? Edema, which would, depending which way it's going, edema is outside of the blood supply. So if we have fluid overload, we could have edema plus excess fluid in here. So if I keep an IV going after it's been canceled by the doctor, I can end up damaging a person's kidneys, definitely. Anything else? So fluid overload, high blood pressure, those are hard on the capillaries. Diabetes is also hard on the capillaries because that high sugar content is hard on the glomerulus and causes damage over time. So people with diabetes end up with kidney disease if they don't manage their blood sugars. Now, I have young students in our class, maybe not this one, but in past classes or in my other class, that have type 1 diabetes. And it doesn't mean that they're going to end up like the people we see in the hospital. If you control blood sugars, people can live a very long life. But it's people that don't control their blood sugars and don't pay attention to it. Maybe you have relatives like that don't understand what diabetes is and what it does to the body. And then that's when they start to lose their feet and they start to lose kidney function. They lose their eyesight because they're not managing those sugar levels. I think diabetes is the second silent killer next to high blood pressure because that high blood sugar, people don't feel the high blood sugar, but it's killing their tiniest of nerves and capillaries. Yes? No. No, no. We already did capillary dynamics, so I just want you to see that conceptually that glomerular pressure has to be the highest. And factors in the way we take care of ourselves can lead to increased glomerular capillary pressure, which is damaging to the kidneys. Yes?
There's another thing also, like that active diet, where you just eat meat and you just try to let your fat burn out.
Mm-hmm.
That's not good for your glomerulus because there's something in the liver called ketones that'll destroy the nephrons as well.
Yep, he's talking about the ketosis-induced diet, the Atkins diet, and that's a hard, high-protein diet. Yeah. Yes. And what does protein do? We talked about if we have a lot of plasma proteins, what does that do for blood pressure? We have a lot of plasma proteins. Pulls water into the capillary, right? And when we break down those proteins, we have that produces urea, which plays a role. We're not going to talk about urea, but it does play a role, kind of a complicated role in the nephron. We're not going to talk about that. But that excess urea in the blood from a high protein diet is hard on the kidneys. Good point. Okay, so again, here are the 3 different processes that occur in the kidney, and just follow the arrows so you can see one goes from the blood to the nephron, number 2 goes from the blood to the nephron, and number 3, reabsorption is going from the nephron back to the blood. So we call this reabsorption because where was it absorbed the first time? If we're reabsorbing it to the blood, where was it absorbed to the blood to begin with? Let's see, we're talking about sodium and glucose. What? No. It's in the blood, and we're reabsorbing it back to the blood. So it's leaving the blood in the glomerulus. But how did it get there in the first place? Where did glucose and sodium and chloride come from to begin with? We just talked about it on Monday. Yeah, the digestive tract. So we absorbed it from our digestive tract into the blood. Now it's in the blood, passes through the liver, and then goes to the glomerulus, squeezed out of the blood, right, in the glomerulus, and now our body, our nephron, is going to, through active transport, send that back to the blood, reabsorption. So that's where the reabsorption comes from. We absorbed it first out of the digestive tract into the blood, then we squeezed it out of the blood at the glomerulus. Now we're going to reabsorb it back to the blood later on in the nephron. So I don't expect you to know the difference among these and which one, how each one is transported. Don't worry about that. Just know that when we talk about reabsorption, it can be either passive, like osmosis, diffusion. It can be active transport, where we're working against the concentration gradient with the use of ATP, or co-transport, where we're moving two substances together. So that's all you have to know. You don't have to go into the details of that. So each segment of the nephron is specialized to move certain things. So again, in the proximal convoluted tubule, we said 100% of the glucose and amino acids are reabsorbed back to the blood. They never enter the nephron again. They're out of there. Okay, we need those back in the blood. So should we see glucose in the urine if our kidneys are functioning properly and we have normal glucose levels? Never should you see glucose in the urine unless you're really stressed out. Maybe you ran a marathon or something and your body's under stress. But typically, never should we see glucose in the urine unless glucose sugar levels are so high the kidneys can't keep up and the person has diabetes. So all the amino acids and sugar are reabsorbed back in the blood. They do not show up in the urine. And then sodium and other ions are removed. Most of the sodium, over 60% of the sodium that enters the nephron goes back. The rest, and the water. But the rest that remains, on the descending limb, we said water leaves. On the ascending limb, some of these other ions, primarily sodium, focus on that one, goes back to the blood. So you do have to know, descending limb is water, ascending limb is sodium, leaving. And then at the end of the nephron and the collecting duct, we have this hormone called ADH. What did I say? The distal convoluted tube. Did I say it backwards? The descending limb, water moves out. The ascending limb, sodium moves out. Did I say it backwards? I might have. Okay, and then in the distal convoluted tube and collecting ducts, there's this hormone, antidiuretic hormone, which is what we call the anti-P hormone. We'll talk about that in a minute. So this diagram just shows how we have movement. Here's the nephron. We see water flowing out on the descending limb. So this is the descending limb. And this is the ascending limb where sodium is moving out. We'll talk about secretion. So secretion is some of it occurs in the proximal convoluted tubule, most of it occurs at the distal convoluted tubule. So we get excess ions, like hydrogen ion, potassium ion, at the distal convoluted tubule that are added to the urine. And the urine is slightly acidic, so it has a pH less than 7. And again, that is because we're getting rid of excess hydrogen ion, and also helps keep bacterial counts low if we should have, bacteria coming up through the reproductive tract. Or not reproductive, urinary tract in females anyway. So the kidneys, the nephrons, are able to concentrate urine depending on how much water is available. So the more water we bring in, the more of that water stays in the nephron, and we produce a large amount of dilute urine. If we have less water coming into the body, then the amount of urine in the nephron is low and more concentrated. And we know that, right? If you've been up all night vomiting with diarrhea, you're probably not going to be urinating very much because the nephrons are very efficient at conserving water with the help of a hormone. And the main hormone, just for this one here, I'm going to actually just delete this slide because this is more detail than we need to know. So I'm going to get rid of that slide. So just cross that one off. So this important hormone is called ADH, antidiuretic hormone. And 4 hormones are responsible for maintaining blood pressure in the body, and you should know just briefly their functions. So ADH, what that does is it increases water reabsorption in the distal tubules and collecting ducts. Antidiuretic hormone. Another way to describe this is the anti-P hormone. So it causes us to reabsorb water at the end of the nephron. So there's less P that you're going to make, right? Because you're reabsorbing it back to the blood. And when we're dehydrated, ADH production goes up. And what secretes ADH? the posterior pituitary in our brain. So we're constantly sampling the environment to see what the concentration of solutes are, and if the concentration of the blood becomes higher, that means there's less water in the system. That's going to increase ADH production and make sure we save any water that's coming in through the digestive tract. And there's a little bit of water produced by metabolism. So this anti-P hormone is always acting to increase water reabsorption if water levels get low. What happens if you're out with friends down on 3rd Street celebrating the end of the semester, drinking lots of beer or some other kind of alcohol, and all of a sudden you feel the urge to go to the bathroom again and again and again, right? And your friends say, oh, once you break the seal, that's it. Well, what is that? What is the seal? It has nothing to do with the urethra. It has to do with ADH production. Alcohol in high amounts blocks ADH production. So if you're blocking the anti-P hormone, what's the effect of blocking anti-P? P. You're going to urinate a lot. So what you're peeing away is your plasma, because the glomerulus is filtering out that plasma. It's supposed to be reabsorbed back to the blood from the collecting duct, but it's not. It's entering the bladder and leaving the body. So it's important when you're going to drink maybe a lot of alcohol over a course of a night, have some water in between there, rehydrate yourself, or at least before you go to bed, have a big glass of water. It will make a difference. That dry mouth, yucky feeling in the morning, a lot of that is dehydration. Another hormone that is produced in the adrenal cortex that acts on the kidney. So these are not produced by the kidney. They act on the kidney. So ADH is produced by the posterior pituitary. Make sure you know that one. That's, I think, on the final exam, if I remember correctly. So it increases water reabsorption. Aldosterone increases sodium reabsorption on the nephron. So it's secreted by the adrenal cortex. Remember that gland that sits on top of the kidney and has an outer margin and an inner margin? So the outer margin is what secretes aldosterone. And a way to remember this, when I was in nursing school, if you look at it backwards, get rid of the own. See where it says RETSOD? That's how I remembered it, as retain sodium. So if you just kind of read the middle of the word backwards, it gives you the answer right in there. So helps you retain sodium, and that's produced by the adrenal cortex. Renin is actually produced by the kidneys, and what that does is that goes through a series of reactions to raise blood pressure. So essentially all you have to know about that is it acts to increase aldosterone production and constrict our blood vessels. And that helps to raise blood pressure. So the key thing with renin, I want you to know, is it increases blood pressure by constricting the vessels and increasing aldosterone production. So if we increase renin, we increase aldosterone. So this is, remember, these are hormones, so these are secreted to the blood. Increases blood pressure and constricts blood vessels. Not directly by going through a series of reactions that involves other hormones, but without renin, you're going to have less ability to control blood pressure. So when blood pressure is falling, your kidneys can't secrete renin to bring blood pressure up if your kidneys aren't functioning correctly. And then atrial natriuretic hormone. This is produced by the walls of the atria when they stretch because of too high a blood pressure. They secrete this hormone to the blood, which will inhibit ADH, so it's going to cause you to pee, and it's going to reduce the ability to concentrate urine. Which one? Now, what is that one? I got to remember. Reduces it to concentrate urine. Inhibits ADH production. Yeah, as a result of, because ADH allows us to concentrate urine, it acts on the collecting duct. So if you inhibit ADH, you reduce the ability of ADH to act on the collecting duct, which will concentrate urine or make more dilute urine. So this is the only one of these two that acts to lower blood pressure. Aldosterone and renin will both increase blood pressure. So the kidneys are really important for blood pressure. So we have these different receptors for ion or solute concentration and pressure that influence ADH release via the help of the hypothalamus. So ADH, again, we said it will contribute to vasoconstriction, which will when you make a blood vessel smaller, that's going to increase blood pressure. And again, getting more water out of the nephron back to the blood, that increases blood volume, which will increase blood pressure. So ADH also increases blood pressure. So the only one that doesn't is which one again? Yep, ANP, atrial natriuretic peptide, correct. So there's a special type of diabetes, which is called diabetes insipidus. And this happens when we have this ADH production, but the kidneys do not respond to it. What causes that? It might be a virus. It might be abnormal condition within the pituitary gland, where the pituitary gland is not functioning properly and there is no ADH. Sometimes, I don't want to get into too much pathophysiology, just leave it at that. So what happens is if you have too much ADH or a failure of the kidneys to respond to ADH, remember what we said about the volume of urine entering? We would pee away our plasma in 30 minutes, but a lot of that reabsorption occurs at the proximal convoluted tubule. A major influence is also this ADH on the collecting duct. So if that process within the collecting duct is dysfunctional, now you're peeing large volumes of urine. I mean, you'll be up all night urinating away. And the way they can tell diabetes mellitus means honey, and insipidus means clear or water-like. So diabetes means to stand with the legs apart. That's what diabetes means in Latin or Greek or whatever it comes from. So it's referring to increased urination. People with diabetes, the regular insulin failure kind of diabetes, urinate a lot, but they have high sugar in their urine. People with diabetes insipidus urinate a lot, but they're just peeing away their plasma. So the way they used to test between the two different types of diabetes years ago was to taste the urine. Aren't you glad you're not a doctor or a nurse back in the old days? If it tasted sweet, they knew it was diabetes mellitus. If it tasted watery, they knew it was diabetes insipidus. And they're two different causes, two different treatments. So pretty gross. So again, here we can see how aldosterone would increase blood pressure, because if we take salt out of the distal convoluted tubule back to the blood, what do we know about water? If I increase solute concentration in a space, does water flow into that or out of that if I have a high concentration of salt? Into it. So that's why people should not be on a high salt diet if they have high blood pressure, because that's going to pull water into their blood vessels and give them even higher blood pressure. So we've got to really watch salt and solute concentrations in the blood of people with high blood pressure. And here, like I said, there's there's a pathway here that leads to this, and this is where renin will help this pathway begin. You can see it right here. It's released by the kidney, which causes this process, which acts on the blood vessels and produces aldosterone. This is more of an advanced concept. All I want you to know is aldosterone is produced by the adrenal cortex, causes the kidneys to retain sodium, R-E-T-S-O-D, retain sodium, which means it goes back to the blood and acts to raise blood pressure. So blood pressure, when it increases, what that does is causes that afferent arteriole to increase, constrict, I was reading this, to constrict so we don't damage the kidneys. That happens initially, but if we have chronically high blood pressure, that mechanism will damage the kidneys over time. So when we are stressed and we have epinephrine flowing through the body, our kidneys respond to that stress, because do we want to spend time filtering the blood if we're stressed? Where should that blood flow go? Fight or flight. We're going to run, right? We're going to run away from that bear. So do we want to send blood to the kidneys when we're running from a bear? Is that a priority for the body? No. So when we're stressed and have sympathetic overdrive because of stress, renal flow, kidney flow decreases. So we are not filtering our blood as efficiently when we're stressed. So the kidneys are affected by stress, because that constricts, that hormone acts to, or the impulses to the kidney from the sympathetic nervous system act to constrict the arterioles. and of all blood vessels, right? There's sympathetic stimulation of all blood vessels constrict under sympathetic, and outside of the muscles and the heart, right? Because that we need increased blood flow to. So we have decreased blood flow to the kidneys when we're stressed. So it's important that, again, we balance our stress so we have good kidney function. Two terms, plasma clearance and tubular load, are things that are measured when we're looking at the kidney to see how well they're functioning. So tubular maximum just means that we're looking at glucose. The kidneys can manage 320 milligrams per minute of glucose entering the nephron. The kidneys can handle that amount, which means that they can reabsorb that back at the proximal convoluted tubule. Anything 320 milligrams per minute or less, the kidneys can handle. So if that's coming into the Bowman's capsule, into proximal convoluted tubule, kidneys can keep up and they can put it back to the blood by reabsorption. Anything more than that, let's say you have 350 milligrams per minute coming into the kidney, how much is going to end up in the urine of that glucose? 30 milligrams, right, per minute. So the kidneys can handle 320. Anything over that is going to spill in the urine. So can you see why a diabetic would probably have more than that entering into the nephron, and the nephron can't keep up, and as a result, that ends up in the urine. So how we urinate is called micturition. Another name for urination, definitely know this term, is called the Micturition Reflex. And it's a series of action potentials that go to and from the sacral region of the spinal cord. But the higher cerebrum, our thinking part of our brain, can influence this reflex. So here's what happens. Step number one, urine starts to fill the bladder. So number one, we have stretch receptors in the wall of the bladder that send impulses to the sacral region of the spinal cord. That reflex via an interneuron comes back out to the bladder wall and contracts it. Now, would that make sense? Why would you want to contract it? All is a reflex. You know, we need to control when we go. Well, that's when you feel that little twinge, when you feel the urge of, oh, I have to go to the bathroom, when you're just sitting there quietly thinking, oh, I didn't think about that, but now I do because this reflex is happening. So what you do then with your higher brain, you say, not now, class will be done in another 8 minutes, then we'll think about it. So then you inhibit that reflex, and then it stops and it goes away. And then you'll be sitting for a little bit longer, then pretty soon you feel that twinge again. That reflex comes again. And then with your higher brain you say, not right now. Until eventually, and then there's another neuron here that controls the external urinary sphincter, so that will keep it reflectively closed until you're ready to go. But then it becomes a point where you can't think about anything else, right? This reflex, you try to inhibit it, you can't inhibit it. All you feel is that constant contraction, and you're holding this sphincter tight, thinking, I have to find a bathroom right now. So that is where the cerebrum can't repress it anymore, and then you go to the bathroom and you go. Or other times, this is important, like if you have kids, classic example. This reflex and urination dominates under parasympathetic overdrive. So when, not overdrive, but dominance, when we're relaxing. So let's say you're going on vacation. Everybody's packing the car. Come on, we got to go get your bag. Don't forget this. Who got the camera? Where's the dog? Did we feed the dog? All that stuff. You get everybody in the car. You finally pull away, and it's like an 8-hour drive, and you're about 2 minutes onto the interstate. I have to go potty. What? Right? Why didn't you go before we got in the car? Because I didn't have to go then. Well, that's true, because when the kids are running around the house and everybody else is running around the house, this reflex, we're not paying attention to this reflex because the sympathetic nervous system is dominating. And have you ever done that for yourself? You have to go to the bathroom. Maybe you're doing your makeup for the girls. And then you're doing this and doing that. You're going to be late. You're going to be late. And like, I have to go to the bathroom. But then, I got to grab this, got to grab this. And you're driving in the car and you realize, I'm supposed to go to the bathroom, right? So we even do that ourselves. When we're busy, we ignore this reflex. We inhibit it with our higher brain, and you don't become aware of it again until you're sitting quietly. Some people, though, the elderly people in the nursing home, have what we call a neurogenic bladder, which means this reflex and this connection with the brain is disturbed with age and whatever caused it, we don't know. But that is one reason why a person is allowed to have a long-term urinary catheter in the nursing home, is because they have dysfunction of this pathway, and it's called a neurogenic bladder. So as we age, what do we get to look forward to? Unfortunately, we can't really stop the process of loss of nephrons. We can take good care of our kidneys by controlling blood pressure and alcohol intake, but over time we do lose nephrons. They become, they break down, and we have less of them as we age. And because of the kidneys just slowing in their function, we have a lower ability to control our blood pressure. How many people here know elderly relatives on blood pressure medication? A lot, right? It's a great thing to go into if you're a drug manufacturer. Find a new blood pressure medication, because a lot of people are on blood pressure medications. Less ability to synthesize vitamin D, and that's why as we age, we tend to be vitamin D deficient, and we have linked vitamin D to depression and anxiety, so depression and anxiety also goes up as we age. So that's why they recommend that everybody in this room and older, take 2,000 milligrams of vitamin D every day. And again, decreased ability of the nephron to do what it does. So what does that mean as a healthcare application? I have two patients. One is a 25-year-old in with a broken leg, and I have an 85-year-old in with an infected foot. So both of them are in pain. Both of them want codeine, or hydrocodone, as a pain reliever. So I give both of them their hydrocodone, and according to the drug book, it says it'll be peaking at this time and it'll be out of their system at this time. Can I rely on that for both of these individuals to say that they're both going to be clear and I can dose them again exactly 4 hours later? Not if it's filtered by the kidneys. Some drugs are filtered by the liver and metabolized by the liver, some by the kidneys. I didn't check what hydrocodone was. I was just using that as a generic example. It could be a liver thing, I don't know. But the point is if it's a drug that's filtered by the kidneys and that is an elderly person, they're in danger of toxicity with that medication, because their nephrons aren't going to filter it out, and it's going to remain in the blood longer than a 25-year-old. So we really have to be careful with drugs and looking for side effects of toxicity in our patients that have declining kidney function. And if I have a patient that's on dialysis, which means their kidneys aren't working, and we have to send their plasma through a machine that filters out the solute, or filters out the waste but keeps the solutes in so they don't die from loss of glucose and all those important solutes, are they going to be making urine? Do I go into their room and say, hey, did you need to use the bathroom? You got to pee? If they're on dialysis? No, because they're not making pee. Their pee is essentially being created by the machine. They don't have kidney function anymore. And these people go to the dialysis center 2 to 3 hours a day, 3 to 4 times a week. Think about the time commitment of that. And that's the people that go to the dialysis centers are usually people that can't manage this stuff at home, because people that have children that need dialysis, they usually do it overnight. They hook them up to a machine, and this process, and this big bag of plasma water that essentially filters the blood sits on the dresser next to their bed, and they filter overnight. That way when they wake up in the morning, they're ready to face their day, and then at nighttime they do their dialyzing. But what would you expect a person, if you're not filtering, the kidneys are not doing their job, what would you expect that patient to look like prior to dialysis? What would be high? What vitals would be high in a person that is not having filtered plasma? Blood pressure is going to be high. What else would be high? Why is blood pressure high? Because there's too much plasma. They're drinking water, right, through their digestive tract, so they have to really limit their fluids, don't they? So they don't get too much water in their blood that can't be filtered out until they get to dialysis. So blood pressure is going to be high with what water they're bringing in, and weight is going to be high. So one of the things we measure in patients prior to dialysis is what is their blood pressure, what is their weight. And when they're done, we have to measure what is their blood pressure now and what is their weight, because we don't want to overdo it. We don't want to crash blood pressure, right? We want to make sure we're keeping them in a somewhat of homeostasis for their bodies. But it's kind of hard when you're relying on a machine, because our bodies right now are doing it via these delicate receptors in the brain and hormones, right? But if your kidneys aren't there to respond to these hormones, or they're shot, you have to rely on the machine. All right, I'm going to look at that homework assignment. We got a couple minutes here. This is pretty straightforward. You're just going to color the different parts of the nephron and label it. So be sure that you use the different colors and labeling. And let's just talk real quick. Sodium leaves primarily where? What part of the nephron do we say sodium leaves the nephron and goes back to the blood? Ascending limb. And where else? Most of it occurs in the, what's the primary site of reabsorption in this nephron? Proximal convoluted tubule. Okay, urea. That's going to be at, you know what, actually I'm going to give you a textbook reference, then I don't have to go over each one of these. It'll just be quicker and you can see it. This is on page 971 will help you with all this. I want to go to the next page. This one is more important. What should we see in a normal sample of urine? Should we see urea in a normal sample of urine? What? Yes, it's a waste product from protein metabolism. Should we see sodium? Yes, we definitely don't have a problem with excesses of sodium. Should we see glucose? No. Bilirubin? Yes, that's a breakdown of red blood cells. That's what makes our urine yellow, is bilirubin. People with liver failure will have a very dark urine because they have too much bilirubin because the liver is not helping convert some of that. Proteins? Nope. Nope, maybe a few, but pretty much no. So you should check urea, sodium, bilirubin, yes. Pus? No. Blood? No. Water? I hope so. Yeah. All right, so the rest of this I'll have you work on your own based on the notes. It's not too difficult, but make sure you have that ready for Friday.